So we have 5 more minutes to go, sir.
That's fine.
Yeah.
You let
So
me know.
before starting, we'll adjust your camera, sir, because no, you need. Yeah, now it is good.
Yeah. But I
Yeah,
was
now it
sitting
is fine.
back. Don't worry.
Yeah, now it's fine, sir.
Good.
Hmm. So Priya ma'am, can you unmute yourself? So we have 1 minute to go, and
Yeah,
I'll
Vishal.
tell you. Yeah, I'll tell you. I'll give you a cue, and then you can start. So
Okay.
you will introduce Dr. Preto, and then Preto will take charge.
Sure, sure.
Yeah. Yeah, you can start now. Over to you, Dr. Priya.
Thank you, Vishal. Good evening, all doctors. We Lupin Diabetes Care team would like to welcome you all for an extraordinary session of Dr. Stefano Del Prato on the topic management of diabetes with COVID-19. We all know that diabetes is one of the most important comorbid condition that is linked to the severity of this coronavirus infection. Patients with diabetes, they are at higher risk of developing complications, including ARDS and multi-organ failure. And seeing the global region, it is seen that 20 to 50% of the patients with coronavirus disease pandemic has diabetes. So giving the importance of the link between COVID-19 and diabetes, we have arranged this session to help you understand deeply on how can we manage diabetics with or without COVID-19 during lockdown. Let me introduce Dr. Stefano Del Prato. We all know that he is a current president of EST 2020. He was the past vice president of the EST. He is currently the professor of endocrinology and metabolism at University of Pisa School of Medicine and is the chief of section of diabetes at University of Pisa, Italy. He is also the past president and honorary president of the Italian Society of Diabetology. He is the current chairman of the European Foundation for the Study of Diabetes. Dr. Prato has main research interests, which are physiopathology and therapy of type 2 diabetes and insulin resistance. Along with that, he has published over 400 articles in peer-reviewed international journals. So we all would like to thank Dr. Del Prato for accepting our invitation to speak and discuss with us on how can we manage diabetes with COVID-19 during lockdown. So along with this, I would like to inform the audience that they can write their questions in the chat box whenever needed, but we will be taking your questions once our session gets over to discuss about the same. So over to Dr. Prato.
Dr. Priya, thank you so much for your kind words and nice introduction. And let me tell you that it's a great pleasure for me to be able to discuss with esteemed colleagues in India what is a current challenging situation of the coronavirus infection, and in particular, the incredible impact that this is having on the people with diabetes. So what I'm going to do is just to go through some of the issue related to the relationship between diabetes and the coronavirus. And also I'm going to share with you what is done here in Italy. And not they know that what is going on in Italy is the best solution for the situation, but it's just a matter of among colleagues to share experience, to share ideas, and to share information. So again, thank you very much, Dr. Priya, for this nice invitation. These are my duality of interest. But let's jump on what is the problem. And the problem is very nice defined by figures, numbers. And this is the last figure that I managed to download from the net. This is refers to yesterday, and it's up to yesterday, at least to this site here.
Dr. Stefano, sorry to interrupt in between.
Yep.
Could you keep your PowerPoint presentation in full screen, please?
Oh, yeah, sure. Thank you. Here we go. Thank you very much, Dr. Priya. Okay.
Yeah, thank you, sir.
So what I was saying is that, the total number of people that have been affected by the coronavirus, according to this website here, the Health Map Organization, the total number is more than 3 million of people around the world. As you can imagine, this infection started off, as you know very well, in China. It spread westbound, hitting all the almost every country, with some differences, however, across countries. And here is the split. for the number of people that got infected by the coronavirus across the countries. You can see the USA is leading the ranking, but also you can appreciate how the Italy and Spain just following behind very shortly. And now you can also see where India is according to these figures here. India is currently in the 13, 14, if you want to use this expression, ranking for the number of people affected with the COVID. I really like to thank Dr. Priya because she provided me with data on your country. And here is the data for your country as per this morning. So the number of people with confirmed infection with COVID in India is being estimated around 60,000 people. Out of them, 1/3 or close to 1/3 recovered, but close to 2,000 people have died because of the infection. And if you do a little math here, you can calculate that the fatality rate is in the range of 3%, which is not that far away from what has been reported in other countries. China, for instance. You may remember China was the first one, and China has reported that the fatality rate was in the order of 2.3, 2.5%. And China was among the first to point it out that there are specific subgroups in the population that were exposed to a greater risk of a more severe condition, if not with a greater risk of dying because of the infection. And this population is the population representative of those with cardiovascular disease, with chronic respiratory disease, with hypertension, with cancer, and of course, with diabetes. Now, according to this early analysis of performed in China, 7.3% of the people dying because of the COVID-19 had the diabetes. In my country, just to share an information with you, this figure has been very much higher. It has been calculated that among the COVID-19 positive in people, 13.1.3% had diabetes. Now, I'm going to give you more insight on this and just taking advantage of information that has been released just a couple of days ago. As you can see here, this has been posted on May 7th, just 2 days ago. And this is quite nice and I think very interesting because it refers to UK and on a population, a total number of people dying in the hospital of close to 6,000 of them. And what they have done was to link these individuals here with the national registry, including 17 million of people, to try to identify which are the main characteristic or the main feature, or if you want, the main prognostic features for a bad outcome of people infected by the COVID-19. And you can see here, age as expected. As you can see here, being young is sort of protective, but with the people getting older, the risk of dying in a hospital is becoming greater and greater. Gender, I already pointed out to you briefly before, males to be at a greater risk than female. Body weight, obesity, and with increasing the body weight, you can see there is a progressive increase in the risk of death. Smoking is a little bit all around the places here. You can see here, as compared to non-smoking, ex-smoker seems to have a greater risk. People currently smoking seems to have not very much of a risk. Difficult to understand. But one important thing here is ethnicity. And of course, the different ethnicity may account for different risk. And again, the deprivation degree and diabetes. And what is interesting here is people with diabetes versus non-diabetes, and then people with and without, or with a greater or a lower degree of glycemic control, as indicated by these values of glycated hemoglobin, and so on and so forth. And of course, as you can expect, that people with respiratory disease, with chronic cardiac disease, with malignancies, with impaired kidney function, are all people that are at the greater risk of developing or having a worse outcome once infected by the COVID-19. Now, as I pointed out, diabetes turned out to be quite a constant feature for increased risk associated with the infection. So the first question that can come to our mind is, does diabetes increase the risk of getting infected? And this is a totally natural and rational question, because we do know that diabetes may increase the risk of infection. Now, there is not very early data available, but what we know is that, in terms of a glycemic control and risk of hospitalization, we have the prior history or the prior experience of the SARS infection. And what has been done here actually is to calculate what is the relationship existing between glycemic control and the risk of being hospitalized for infection. And on this side, on the right-hand side, the risk of being hospitalized because of infection of the respiratory tract. And what you do appreciate is that there is a relationship between glycemic control and risk hospitalization because of infection, which has a typical J-shaped curve. So having very low glucose or having progressively high glucose concentration exposed to an increased risk of hospitalization. And this is particularly also true, when you look specifically to infection of the respiratory tract. So what do we know now with the COVID infection and diabetes? Now, a colleague of mine in Italy here has done this meta-analysis. And what has been done here was to look at the diabetes prevalence among SARS-CoV-2 infection, people with the coronavirus. And you can see here different cohorts, many of them in China, okay? And what you can see, you can calculate that among the people that have been infected by the COVID-19, 10%, in the range of 10%, had diabetes. Now, if you do consider what is the actual prevalence of diabetes, now it looks like the 10% is not that far away from what is the prevalence in the diabetes in the general population. So to some extent, this suggests that the risk of being infected is not higher in the diabetic individuals because the prevalence of the infected one with diabetes and the prevalence of diabetes in the non-infected general population is quite similar. Now, this friend of mine based in Padova, they also have looked at their own data. And here is the prevalence among people with the COVID infection in people admitted to the Padova Hospital. Here is the prevalence is in the range of 9%. This is the local prevalence of diabetes, the general one, okay? And you can see the prevalence of people with diabetes among those admitted to the hospital because of the COVID-19 is slightly higher. However, if you take into account the population with an average, with an age that is similar to the one of those that have been admitted to the hospital, now you can appreciate there is not very much of a difference between the two. Again, this supports the idea that diabetic individuals, yes, they may have an overall increased risk of infection, but by and large, they do not show a specifically increased risk for infection of COVID-19. Now, we also have looked at our own patient in the hospital in Pisa. I'm, as Dr. Priya pointed out to you, I'm based in Pisa, the University of Pisa. This is the initial assessment, and this refers to something like 120 individuals that have been admitted to the hospital. What we have done here was to look at how many of these patients at the normal plasma glucose concentration at the time of the admission, and how many of them had non-diabetes. And you can see that out of these 120 individuals, 19% had non-diabetes. But interestingly enough, there is an equal number of individuals who had hyperglycemia without not having a diagnosis of diabetes. And now you can start, comparing these three categories here to appreciate that, first of all, people with non-diabetes, as well as people without non-diabetes, tend to be older as compared to people with normal glycemia, tend to be heavier, more obese, or with more overweight as compared to the plasma glucose, people with normal plasma glucose concentration, when there is no difference in terms of the distribution for gender. Now we also look at some of the features of these individuals here, as is shown in this slide. And what you can see here now, again, you have the three categories. And now what we have reported are some of the features, initial features. Now, if you look, for instance, to oxygen saturation, you can appreciate that overall, even the people with a normal plasma glucose concentration, they have a poor saturation. But this is much worse, with no difference between those with non-diabetes and with hyperglycemia without a prior diagnosis of diabetes. The same is true as far as the systolic blood pressure is concerned, slightly higher with no difference in people with hyperglycemia with and without known diagnosis for the disease. Now, as you know very well, the COVID-19 has been also called a cytokine storm, an inflammatory, dramatic response. We have been looking at the number of factors associated with inflammation, associated with coagulation, without really pointing out any specific difference here among these conditions. However, where we found quite a dramatic difference in our own, though small population, is what happened of these people, and in particular, what is the death rate. Now, you can see in this slide, the death rate, or the percentage of people admitted to the hospital dying with normal plasma glucose concentration at admission versus those with diabetes. And now you can easily appreciate how having diabetes is doubling the risk of developing or dying. But what is even more impressive, which also may point out to the potential role of the glycemic control, is what happened on people with hyperglycemia, but without non-diagnosis of diabetes, because in that case, you can see that the mortality rate is even greater as compared to the diabetic ones, as of course is even much greater as compared to the one with the normal glycemia. So this points out to another information here. The diabetic individuals doesn't seem to be at a greater risk of developing the infection, but once they got the infection, they have a much worse outcome with a greater risk of mortality. And this data, although being collected in a small number of people, fits with some meta-analysis. Here again, the meta-analysis performed by Dr. Fadini in Padova, and you can see here when they compare patients with the more less versus those with the more severe versus those with a less severe infection. Now, among those with a severe infection, there are twice as much the probability to have people with the diabetes. And this fits with the number of analyses. These are Chinese data, and these are more data that have been put together. And what you can see here is the rate, hazard ratio, and so on and so forth, and odds ratio for being more severe, to having more severe condition in diabetes versus those without diabetes. Having diabetes increased at least by 2 what is the risk to be in the category of people with a more severe infection. So diabetes is definitely associated with poorer outcome once infection occurs in a person with diabetes. What is the reason? Now, there are multiple reasons to account for that increased risk. Diabetes, and in particular type 2 diabetes, is a syndromic condition. And the diabetes per se, it is indeed hyperglycemia, but it's also association of multiple conditions. For instance, there may be differences in terms of ethnicity. The prevalence of diabetes may vary across different ethnic groups. And also age. The diabetic individuals tend to be older. And we have been seeing how important is the effect of age in terms of the outcome of the disease. Let me just give you a couple of hints on this. Ethnicity. Because ethnicity and age, by the way, could also account for the quite great variability in terms of the mortality rate that has been observed across countries in people infected with the COVID-19. You can see here, for instance, in Belgium, just thinking about the European countries, okay, has at least 5 times higher the mortality than in Germany. And Germany and Belgium are close enough. So what is the reason for that? So again, there may be some factor that can account for this variability in the mortality that could be also linked to some extent to the presence of absence of diabetes. Ethnicity really seems to play a role. These are data that are being reported by the Intensive Care National Audit in UK, looking at the people that have been admitted to the intensive care unit because of critical condition. And you can see the vast disparity existing across the different ethnicity. So what is the reason for that? We don't know exactly, but it may be that even diabetes may be spread in a different manner, or other condition that may be typically associated with an ethnic group. As I already mentioned, age is an important thing for the diabetic individuals, particularly the type 2s, because they tend to be older as compared to the general population. And interesting enough, the elderly people may account for some of the variability that we observe in the mortality rate across countries, not only because of the age, but because of the typical habits in a different country. Let me explain myself better. Now, in Italy, for instance, social life, contact with people is very common. It is part of our tradition, even for elderly people. If you look across Europe, for how often people get in contact with other people above the age of 70, you can find a quite wider difference. So what we have done here was to plot the average daily physical interaction in people over the age of 70 versus the lethality rate at the start of the infection. Now we came out with this incredible straight line. So suggesting that the traditional habits of the population, how often people get together with the other people, may indeed affect the transmission, and because of the transmission also impact into the mortality. And of course, as you can imagine, this also bring in, because the diabetes, because among these elderly people, the proportion of those with diabetes is going to be much, much greater. So ethnicity, age could be factors, but diabetes, and in particular type 2 diabetes, is often associated with cardiovascular disease and arterial hypertension. And arterial hypertension and cardiovascular disease, as we already seen before, and I showed you before, can be associated with the worst outcome. Cardiovascular disease. Here is another information. This is a nice publication in the New England Journal of Medicine. And you can see here, once again, being older is a problem. But if you have coronary artery disease, congestive heart failure, arrhythmia, a chronic pulmonary disease, or you're smoking, your risk of mortality or hospitalization or mortality, is much, much greater. Not only that, but there are other factors that may be associated. It is not just the disease per se, but the disease, or having a cardiovascular disease, brings up multiple treatments. So those treatments could also contribute to differentiate in terms of the risk. And what has been done in this paper was to look at the effect of the using some drugs in terms of the surviving or not surviving. And what you can see here is that if you look at the ACE inhibitors, there is a difference of 6%. If you look at ARB, beta blocker, and so on and so forth, there's very minor differences. Even in terms of the hypoglycemic agents that have been used, or the use of insulin per se. So the different treatments may have some effects, but this also could be of intriguing interest, because there have been some reports raising some question about the potential damage or the potential risk we could expose our patient if they have been treated with ACE inhibitors and ARB. And that's because what has been suggested is that the ACE, the angiotensin converting enzyme 2, may represent a point of attack for the virus on the plasma membranes that facilitate the internalization of the virus, and because of that could increase the risk of the infection. And because of the ACE inhibitors, that could also contribute to increase the expression of ACE2, although the ACE inhibitors, we have to remember, do not interfere directly with the angiotensin converting enzyme 2, but just to the angiotensin converting enzyme. And so it is not completely clear to which extent the ACE and the ACE2 may really contribute to the risk of the infection, and even more, whether the ACE inhibitors or the angiotensin receptor blocker may interfere with that. And to make things even more blurred, there are also animal data supporting a potential protective pulmonary and cardiovascular effects of elevated ACE2 expression. So we don't know exactly. So the recommendation, the current recommendation as far as the ACE inhibitors is concerned, is that don't do anything, don't do very much, don't stop the treatment in these individuals. And actually, to support this view, more recent data have been made available. These are data, again, the same data that I showed you from Dr. Mera, reporting the increased risk in people with cardiovascular condition, but they also look at what is the correlation, the association with receiving ACE inhibitor, receiving ARB, or receiving statins. And you can see here, ARB doesn't seem to do very much. And if any, ACE inhibitor seems to be protective. Now, these data are receiving more and more support lately. And here on the same issue of the New England Journal of Medicine, there is this paper by Professor Giuseppe Mancia. And what they've done here was to look at the people on ACE inhibitors, on ARBs, on calcium channel blockers, on diuretics, on different treatments here, according to the severity of clinical manifestation, the gender, the age of diagnosis, and by and large, you don't see major differences. So using the AC inhibitors may not interfere what is the outcome of these individuals. What it may represent the risk is not the AC inhibitors, is actually the cardiovascular condition and even more the increased blood pressure. So what else could we consider for type 2 diabetes in its syndromic condition? What is very common, particularly in my country, but I also think the same in India, and India in particular, as far as it's considered visceral obesity, is indeed the accumulation of the adipose tissue. And definitely obesity per se seems to be associated to worse outcomes. These are data that have been just again released by this French group. And what they have done here was to compare the distribution according to different categories of BMI, going from low BMI, below 25 kilogram per square meter, to up to a BMI greater than 35. In the distribution of these BMI categories in people admitted to the intensive care unit for non-SARS-CoV-2 infection versus those with the COVID-19 infection. You can see here that obesity plays a major role. There are more obese individuals as compared to the non-COVID infection that are admitted to the ICU. And they are admitted to the ICU because they do require more commonly mechanical ventilation. You can see here the spread between the mechanical ventilation and the BMI, and you can appreciate how people with BMI be greater than 30 and 35 tend to be requiring more mechanical ventilation as compared to those that are not treated with mechanical ventilation. And you can see again the same kind of information in this part of the slide here. Why obesity? Of course, we know that obesity is impairing pulmonary function, but obesity can act through different mechanisms. It can impact directly the lung by reducing the respiratory capacity. It can act through blood pressure, thrombogenic, diabetes, and so on. And all these contribute to lower cardiorespiratory and metabolic reserve. And remember, metabolic reserve for these people can be critical, can be crucial, because they do need metabolic energy to really use the respiratory muscle to maintain sufficient respiration and respiratory function. But it's not only that. Obesity and excess ectopic fat, liver, for instance, or pericardial fat, for instance, do have an effect in terms of inflammation and immune response. And this can jeopardize the capacity of the system to properly respond to the infection, and because of that, to precipitate what is an infection into a much worse outcome. And finally, as we mentioned before, diabetes is hyperglycemia. So the question is, how important is glycemic control? Remember, I already pointed out to you that people without a known diagnosis of diabetes, but with hyperglycemia at the time of admission in the hospital because of the COVID-19 infection, already had a greater and worse outcome. They have a greater rate of mortality. So glucose must play a role there. Now, and this is an information, this is a knowledge that we have, that we got from the past, from past experience. For instance, the prior SARS infection that goes back 14 years ago. Now, it was very clear at that time that the viral infection was associated with a poorer survival if at the time of the admission plasma glucose concentration was higher. And you can appreciate here what is the survival curve for people in the low range of plasma glucose concentration at admission versus those with a higher plasma glucose concentration. But it's not just the glucose concentration at the time of the admission. It's also the plasma glucose concentration throughout the in-hospital stay. And here you can see the comparison between people with the SARS infection who survived the infection or who died. And now you can, as you can see, at admission, those who died had tended to have greater plasma glucose concentration as opposed to the survivors. And you can see different curves here because these are people treated with or not treated and treated with a different dose of methylprednisolone, which is also very much used with the COVID infection nowadays as well. And you can see that it's not only the initial plasma glucose concentration that is worse in those with disease as compared to those surviving, but also throughout the entire period in the hospital, plasma glucose concentration remained significantly higher in those who died as compared to the one surviving. And the same is true if you look at the relationship between glycemic control and plasma glucose concentration between survivors and deceased on the basis of the respiratory function or the saturation of oxygen saturation. And you can see that, of course, survivors still tend to have always a reduction in the glucose concentration as compared to those who died, but also those with a worse saturation for oxygen, they also have greater plasma glucose concentration. So this was the lesson of the previous viral infection. What do we know about relationship between plasma glucose concentration and the COVID-19? Now, as always, data are accumulating and we're having more information. Again, this is a very recent paper that has been published on cell metabolism. And what has been done here is to compare poorly controlled diabetic individuals versus well-controlled diabetic individuals. And you can appreciate how poorly and how well, looking here at what is the plasma glucose concentration in these individuals. The well-controlled ones having a plasma glucose concentration throughout the period in the hospital that was in the range of about 7 millimole per dl, 120, 130 milligram per dl. And now those who were poor glycemic control had a much greater plasma glucose concentration. Here we are in the order of more than 200 milligram per deciliter. Now, these two groups also differentiate one from another in terms of the lymphocytes counts being more lymphopenic, those with a greater plasma glucose concentration, in terms of the neutrophils and being higher in those with poor glycemic control, in terms of interleukin-6 with a trend to have a greater inflammatory response, which is also testified by the significantly higher CRP levels. And LDH has been also controlled as another markers for inflammation. And of course, all this will translate into the chances to survive the infection. And when the survival curve has been calculated, you can easily appreciate how being poorly controlled with diabetes at the time of a COVID infection is associated with a significant reduction in the survival. Now, after 28 days, 5%, 6% of the population has died if they had poor glycemic control as compared to 2-3%. So plasma glucose concentration makes sense in terms of a target for a coordinated, for a comprehensive treatment, which is treatment of the condition, the infection, treatment of the accompanying comorbidities, and treatment of glucose itself. Which kind of glucose control? Now, there is a number of recommendations nowadays. None of them are really based on the specific condition of the COVID-19. Most of them are mutuated from the recommendation for critically ill people with diabetes. But by and large, what is being recommended for people once they are admitted to the hospital, particularly if they are admitted to the intensive care unit, is that plasma glucose needs to be monitored carefully together with electrolytes, pH, blood ketones, and beta-hydroxybutyrate. That insulin should be considered every time, particularly in the presence of a severe adverse condition, IRDS, hyperinflammation, avoiding subcutaneous insulin injection and favoring intravenous insulin infusion. And of course, not all patients will require insulin. We'll come back to that in a moment. But in all patients, the aim should be to try to maintain glucose concentration between 4 and 8 millimole, between 72 and 154 milligram per deciliter, trying to avoid as much as possible hypoglycemia. And of course, that can be done with the different drugs, with a number of drugs. This is the general armamentarium that we may have nowadays: metformin, SGLT2 inhibitors, GLP-1 receptor agonists, DPP-4, sulfonylureas, pioglitazone, insulin, and all of them, even in the specific condition, may have pros and sometimes may have some cons. Now, metformin, we know that metformin is associated with the risk of lactic acidosis, and hypoxia can be a problem in people with COVID-19. So that should be stopped in people at risk of developing hypoxia. SGLT2 inhibitors, we know that SGLT2 inhibitors can be associated with the risk of dehydration and glycemic ketoacidosis. So again, seek their rule, stop it if there is a severe condition. GLP-1 receptor agonists, we'll come back to that, but one consideration for GLP-1 receptor agonists is that GLP-1 receptor agonists can cause nausea and can cause vomiting. And in the case of vomiting, we may be concerned about potential aspiration. So again, in severely ill patients, it would be cautious to stop the treatment. DPP-4, low risk of hypoglycemia, possible use in a wide range of renal function. It may be continued with insulin in these patients. There is no particular contraindication for the use of DPP-4 in people with diabetes and COVID. Sulfonylurea, the usual problem of hypoglycemia, and stop sulfonylurea, particularly if you start with the insulin, and particularly if people do not have a normal and regular nutrient intake. Pio, fluid retention, edema, again, that should be considered very carefully in this patient that can be very ill, and insulin remain a drug of choice in critically ill patients because it can be titrated. Although remember that if insulin is used, try to avoid use of subcutaneous insulin preferred. And if you have to use the subcutaneous insulin, don't use the sliding scale approach because that can increase the risk of hypoglycemia. But there is other consideration. For instance, intriguingly enough, DPP-4 have been suggested that could have a potential interaction with COVID-19. In fact, soluble DPP-4 serves as co-receptor for a subset of coronavirus. So inhibiting the DPP-4 could hypothetically provide some sort of a protection, although we still need information. This is just an hypothesis based on some preclinical data. I think that in the future, we will have enough data also to analyze what is the specific effect of the different treatment the patient were on at the time of the infection to see whether the different treatment could have provided a differential risk in terms of increasing, improving, or worsening the risk of these individuals. And that will have to do in particular with the DPP-4. I mentioned to you about the GLP-1 receptor agonist. I did that for a very simple reason, because it is true that we need to be aware of the potential risk of aspiration. But also, it's intriguing to consider that GLP-1 receptor agonists reduce inflammation. I showed you the relationship between having poor glycemic control and CRP in a couple of slides before. And you can see here the reduction in the CRP that has been noted in a number of intervention trials with the use of GLP-1 receptor agonists. So whether this may provide an opportunity, we don't know. Again, we will need to go back and look at the data carefully and try to learn more. But overall, what we need to do in terms of managing people with diabetes at the time they have a symptomatic infection, symptomatic non-severe illness, or severe illness, we need to make sure that we do improve glycemic control and maintain good glycemic control. And of course, taking into consideration all the pros and the cons of all the different treatments that we have been discussed just a moment ago. But not only that, I already mentioned to you that type 2 diabetes is a syndromic condition. So it's treating hyperglycemia, but it's also treating the cardiovascular association. So ACE inhibitor, statins, aspirins, it says here caution, but I showed you that at the time when this was released, we had not yet all the data that have been published, like the one in the New England Journal of Medicine that I showed you before, showing that ACE inhibitors apparently do not increase the risk for these individuals. But there is another aspect that I think an endocrinologist and diabetologist, if it is has to follow someone which is admitted to the hospital because of COVID-19, must keep in mind. And is the relationship, or if you want, the interaction between glucose lowering agents and specific therapies like antivirals and immunomodulators. I'm not going to make you tiring looking at these very busy slides, but these slides just want to have a concept conveyed to you. There are potential interaction between glucose lowering agents and treatment, antiviral treatment, or treatment that is being proposed for the use of the COVID. So we need to be aware of that. Just to mention the chloroquine and the risk of hypoglycemia, or you can see here interaction with the number of antiviral drugs. So this is what we need to do for people once they are admitted to the hospital. But we have to make sure that we do not forget those that are out there, not being infected by the COVID-19, but maybe sort of neglected because of the intensive care that is paid to those people that got the infection. This is a quote that I like very much by Dr. Kittleson, published in New England Journal of Medicine. Overwhelmed by the anticipated harms of COVID-19, we must remember that other disease, and like to quote diabetes, continue to progress during the pandemic. Continue to progress, and remember that progression of diabetes means more and increased risk for complication. So we need to take that into account. It's not just the person with diabetes with the COVID infection, but it's also making sure that the multitude, the population at large with diabetes that remain at home because they are confined, because of the lockdown, they still need to have contact with the healthcare providers. And then can be done remotely. And I do believe that this remote way to follow diabetes may be changing our way, even in the future, we'll be treating diabetic individuals. So, and it's important to provide this teleconsultation. And I can tell you, this is what happened in my country. Again, sharing information with you. The Italian Society of Diabetology, the Association of the Diabetologists from the hospitals, the Italian Society of Endocrinology has recommended using telecare. And this is also a flowchart. I'm not going to take into the flowchart. The message is stay in touch with your patients. Why is that? Because if they're not staying in touch, they may be losing confidence with the sum of the basic measure needed to maintain good glycemic control. This is an interesting survey that has been performed in the United States, and the same is ongoing right now in Europe. So people, they went back to people with the type 1 diabetes, adults ones, and children, and people with type 2. And they asked them, how much the infection, or being at home because of the infection, or because of the lockdown because of the infection, is impacting in your diet and your exercise. And you can appreciate that 30 to 40, 50% do mention that this has impacted. Less attention paid to the diet, less exercise. And I'm sure that with less attention paid to the diet and less exercise, the A1C would be floating up. And that would mean losing glycemic control. But it's not only that, the reason why we need to keep contact with our patients. This is one reason. Our patient may need us in order to cope with the demanding request coming from the situation. Again, the same kind of questionnaire or survey that has been performed. You can see how people with diabetes are getting more and more concerned about the family and friends, of course, but also concerned about getting infected, concerned about the financial situation, and concern means more depression. And more depression means less ability to cope with the adherence to the treatment. And with the less compliance to the treatment, together with less attention paid to the diet, less attention paid to the physical exercise, also means losing more control. This meta-analysis shows you that because of the depression, you have a 30% increase in the risk of being less compliant to the treatment in chronic condition. So keeping the touch, keeping the contact is important. And there's a third reason why it's so important. Because people with diabetes, because they are afraid of the condition of the pandemics, they tend to be neglecting some symptom or signal that may be associated with a rapid worsening of condition associated with diabetes. So the contact allow us to be aware of that situation, and because of that, to be able to organize an immediate face-to-face contact with them. And all this also would require a sort of a societal approach where we need all the support that can be provided through maintaining and reinforcing patient education, through defining clear point of contact for all patients, for reiteration of sick day rules, for repeat prescription for supplies, being proactive in reviewing the need of our patients. This is the best way not to have them to lose control and maintain the best control that may also reduce the risk for worsening. And this has been translated in my country in a number of recommendations that is summarized in this cartoon here, that is valid for the general population and that can be incorporated with a specific recommendation for the diabetic individuals. Keep a well control of your condition. Monitor regularly your blood glucose. And if your blood glucose starts not being controlled, contact your doctor in order to establish what is needed to retain and regain good glycemic control. So what we need to do in terms of the managing the people with diabetes is to try to do our best to prevent the risk associated with poor glycemic control, which also include the infection. And also we need to work through all the different measures that we've been reviewing, but also there are other aspects. We may also need in the next future that what we call in our country now the phase 2 after the phase 1, that was the active epidemics, that is, protecting in the second phase more people. And that may require serology screening, maybe in the future vaccines, or some chemoprophylaxis. But again, what I think is important here is to keep the touch, to keep in touch with our patients. So really we are facing a world that is changing. And this world that is changing may require also to reconsider a number of strategies that we have been implementing for the treatment of type 2 diabetes. We may remember that people with diabetes are a vulnerable group. And because of that vulnerability, they may be at a greater risk for outcomes. They may also be exposed to a risk because there may be some interruption in the care providing. And we need to make sure in order that we stay in touch, as I repeated that over and over again now, with our patients. And because of that, we should be able to install preventative and curative intervention to try to reduce the priority and be ready to face those priority. And of course, this will lead us in a better capacity to building emergency preparedness. In other words, I think that the COVID-19, even for the diabetes, in particular, I'll say for the diabetes, should trigger changes in our way we are facing diabetes, providing with adaptive strategies in the health service, and in particular in diabetes. I think that the world will not be the same as before, and that may also change our way that we are using to provide healthcare to the people with diabetes. And I hope I have not annoyed you too much. And I really thank you very much for being with me. And I'll give it back to, hand it over back to Dr. Priya for any question. I'll be happy to try to answer any question you may have. Thank you very much.
Thank you, Dr. Prato. It was very insightful and interesting to know how we can manage diabetes with COVID-19 patients. So now coming to the question answer session, we have few questions that has been arrived from the audience. One is that we have a suggestion from one of our doctors. So we would like to understand what is your opinion regarding that suggestion. He has mentioned that SGLT2, gliptins, and bioglitazone are best to be avoided. Metformin is okay for stabilized patients. Glimepiride and glycoside can be used for stable patients with glycemic control. And insulin is a gold standard molecule in all stages. So do you have any opinion regarding the same? Do you have anything to contradict on that, or do you feel it is?
No, I mean, again, I think that we all, and myself, are mainly based, our suggestion on the basis of what we know about the different drugs and what we have been our experience in the past with a critical condition. Okay, we have never been exposed to this situation. As I mentioned to you before, I would expect many data to be lumped together to look, what has been the impact of a patient being treated with an SGLT2 or being on sulfonylurea and so on and so forth. So that will be a learning curve. Now, I think that at the time being, we need to exert, first of all, an individualized approach. And the colleague already mentioned to that. If I have a patient that is stable, okay, and is on whatever treatment, there is no specific reason to change that treatment. But if I have a patient that because of that condition, maybe, let's say, at increased risk of dehydrating, I may have a thought about using or continue using SGLT2. Or if it's developing fever and is not eating, so that may also be a condition that can put them in a ketogenic condition. So I'd be more concerned in using an SGLT2. If I have a patient that because of the infection, you may have, some instability in its hemodynamic condition, how will I have, concerns keeping the patient on pioglitazone, and so on and so forth. So I think it's important. So what I think is important to remember, there are drugs that may be, let's say, less associated with a fluctuation in terms of the response. For instance, the DPP4 seems to be pretty safe, but DPP4 may not be enough for a patient that is in a condition, a critical condition, where you need something else, like for instance, insulin to keep control of the glucose. So I do not have, let's say, the rule of thumb for telling drug A is better than drug B and C and D and E. Again, we are dealing with a heterogeneous condition, and we need to be good diabetologists and know exactly what we can expect from our drugs and what those drugs can do of good or bad sometime for our patients. And that is the kind of reasoning that we need to do. And so I think it's important to keep in mind what is the potential problem associated with the treatment in the case a heal condition develops. And this is valid for the COVID-19 as well as for any other intermittent serious condition, okay? And what are the potential benefit or the potential neutrality of a treatment with respect to that condition?
Okay. That was good, sir. Thank you very much. Another question is, will fluid depletion from SGLT2 class of drugs affect the type 2 diabetes patients? If so, is there any modifications that is required in the dose? That means, is there any dose adjustments that we need to make for patients taking SGLT2, especially those who are infected with COVID-19?
No, the SGLT2 does not have a dose-dependent effect. Okay, and this is clear even from the, let's say, the beneficial effect of the SGLT2. If you look at the results of EMPOREG, for instance, or other studies where 2 doses of the SGLT2 have been used, there is usually no difference in terms of the beneficial, the good outcome. Okay, if you are on the low dose and the high dose, you still have the same effect. And this is true the other way around. Okay, and in other words, if you do reduce the dose, you do not reduce you just lose the pharmacologic effect. You don't reduce the risk associated with that. So if there is a risk of dehydration for the person with SGLT2, if there is a risk of developing ketones because of an intercurrent condition, what is the recommendation? And it's not my recommendation, but it's a recommendation of the authorities, a recommendation of the guidelines, a recommendation of the consensus, is to apply the 6-day rule. You stop the treatment, patient gets better, you restart your treatment. Okay, so that is important. Don't play around with reducing doses and so on, because reducing the doses, you may just reduce the potency, but not necessarily the risk of the side effects.
Okay. Thank you, sir. Another question is, is there a high chance that well-controlled diabetes, when compared to non-diabetes, are likely to have a lesser risk of getting infected with COVID-19?
This is a great question, but I don't think we have sufficient strong data to suggest that. What we can say is that having better glycemic control versus worse glycemic control makes the difference. Now, if you go back to the data that I showed you at the very beginning, referring to those 600,000 people, 6,000 people from UK, okay, there were three categories there for diabetes. Actually, four categories. No diabetes, which was the referring point, having diabetes in general, and having diabetes was associated with an increased risk of mortality. And then there was two groups: people with an A1C greater than 58 millimolar per mole, whether it is 7.6%, okay, or below or above, okay? And having an A1C above that was associated with an even greater risk as compared to the one having it below that. Now, to which point, by, let's say, ensuring normal glycemia, okay, let's think about the best, okay, can reduce the risk to the same level of the non-diabetic individuals, that is not known, or at least I do not have the data. But from what we know from other critical conditions, the good glycemic control is always associated with better outcome. And I think there is another point to keep in mind, is the fact of the need for treating carefully blood glucose in people when they come to the hospital, or if you are a diabetologist and you see a patient because of, is considering his workout because of potential COVID infection, with a hyperglycemia without a prior diagnosis of diabetes, because in that person, improving glycemic control can be even more critical than in a person with a non-diabetes. And if you think, this makes a sort of sense, because the person with diabetes has been already to some extent controlled, treated. The other one comes from a history of untreated condition. So it really has a bad legacy associated with that unrecognized condition.
Okay. Thank you, sir, for the answer, for your opinion on the same. Another question is, patients with type 1 diabetes mellitus, they are known to suffer from diabetic ketoacidosis at a later stage. Now, during this pandemic crisis, they're asking if the patient is infected, that a type 1 diabetes is infected with the COVID-19 coronavirus, how early are the chances that the patient might develop DKA at this?
I think, let me blunt on this, okay? And forgive me if I feel maybe, I always, consider that if a person with type 1 diabetes under a stress condition, let's say COVID-19 infection, develops a DKA, is because either it was not educated properly, or I'm, being his doctor, I've been not recognizing that he was at risk. Okay? So I think that for any person with type 1 diabetes, nowadays, because of the COVID-19 potential risk of infection, should increase the glucose monitoring, pay attention to how the glucose is behaving, informing immediately the physician, and actually together with that, maybe to have time by time also some ketone body assessment, okay? If immediately getting in contact with the diabetologist and endocrinologist in case he cannot properly intake his or her food, in case is getting fever, in case he has a sign of dehydration. In all these cases, the contact with the physician, with the endocrinologist, diabetologist, is key. And in that case, all the proper measure should be put at work immediately. And if that measure requires admission to the hospital, I would also suggest, if there is a COVID-19 infection, to start immediately a line with insulin infusion in that person.
Okay, thank you, sir. So, can you put some light on how to develop, or is there any guideline that we can say on the treatment option of COVID-19 patients in diabetes according to a patient profile? So,
There is no, let's say, official guidelines, but I would like me to advise you, one, to connect with the EASD e-learning, because you can listen to a number of experts dealing with different aspects of the clinical situation that we have to face day to day: glucose monitoring, use of the pump, telemedicine, and so on and so forth. Okay, so easdelearning.com, and you will have a lot of interesting things there. Not only that, but the interview with the experts comes together with some staff material that you can download that can be very useful. And then there are some flow charts for treatment and so on that are being validated on different international levels in different countries. There is a paper on Lancet DE that I pointed out to you at a certain point that has been published, okay, where also summarized. And there is also a nice review on the different treatments and things to be considered in diabetology, again, that I mentioned to you in my slides. So right now, there is no, let's say, official statement from the ADA EASD in how to change this, but there are different recommendations coming from different expert groups and from local associations. And on the Lancet DE, if some of you may be interested, there will be also recommendation for treatment at the time of the COVID in people with obesity and diabetes that may be suitable for bariatric surgery, and how to, in the future, recover from this situation of lockdown that is also building up a lot of a backlog of surgical intervention, a need for more intervention, and so on and so forth.
okay. So there is one more question that has come up for us. That is diabetes with CKD on dialysis. What is the risk and prophylaxis that should be considered at this time?
Right. As far as we know, again, the CKD or the chronic kidney failure is associated with increased risk in people with COVID-19. Remember that some of these individuals develop a multi-organ dysfunction, and one of the first organ that's often got involved is the kidney, is the renal function. Okay, so in that case, I think intensive care unit is very much needed, and a very careful management and monitoring of a fluid intake, fluid retention, blood pressure, and if there is diabetes, of course, glycemic control is definitely needed, with a regular workout by the nephrologist in terms of what is the frequency of the dialysis for these individuals, or the need to start someone in dialysis soon enough in order to prevent as much as possible the decline in the kidney function.
Okay. So there is one question, sir, that has come up with regards to DPP4 inhibitors and thromboembolism. So there was this initially, it was published in a journal in the month of May in Lancet, that there was a database study by the WHO with pharmacovigilance team suggesting that DPP4 inhibitors has a safety signal of venous thromboembolism. So this was actually not noted in any of the Examine, TECOS or SAVOR trials, but taking this pharmacovigilance study, there was a publication being created. So if you can just throw some light on it, because this has been a kind of communication going on everywhere in India now among the doctors.
Yeah.
So throw some
well,
light on the
again, I think that as I said before, we are in a learning curve, and I think that first of all, we will have, a number of information. Some of them will be directing us towards some specific items, and that will be needed to be explored even more. So I think that you have two different situations here. I mentioned the DPP4, for instance, before, because some preclinical data showed that DPP4 could be a receptor for some coronaviruses. Okay, so you can claim, if that is the case, by inhibiting the DPP4, I should interfere with the infection. Okay, now is that true? We don't know. We need to see the data. Now we can see some signal, clinical signal. Let's say, for instance, some reduction in the thromboembolism in people with DPP4. As you can imagine, we are really playing around with a very, what can I say, heterogeneous group of people. So if that is a signal, that signal will probably need to be explored in a proper manner to really appreciate to which extent the DPP4 inhibition could interfere with thromboembolism or coagulation. You mentioned that very nicely. There was no signal in SABOR. There was no signal in Examine. Sorry, in TECOS. There was no signal in Carolina, in Carmelina, in any of the trial for this. So how to reconcile them? I do not have the explanation. I would say that is something that's being picked up, is a flag. We need to consider any potential, particularly beneficial ones, as well as the side effects, and then go back and check whether there is a potential there. Now, think about what happened, for instance, for the story of the heart failure and saxagliptin at that time, okay? So there was a concern, and then, that was taken very seriously. And then we had a number of studies now, and I don't think there is any concern anymore with the potential risk of DPP4 in general and heart failure. Now we have a signal. We need to go back and check and to see whether there is really, this signal is a real one, and whether we can have a chance to take advantage of that signal and translate that into a clinical relevant signal.
Okay. Thank you so much, sir, for the insight. And now we have the last question, and you being the current president of ESG 2020, everyone is eager to know whether we are going to have ESG 2020 happening this year. If so, is it going to be a virtual conference, or are we going to have a face-to-face like last year?
As you can imagine, we are monitoring the situation very, 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 and even more, very carefully. Because first of all, it's an health issue. Safety is the main problem, is the main issue. So I cannot tell you anything specific, but I can tell you that by mid of the month, we will come up with an official announcement of what it's going to be.
Okay.
But in all cases, we do expect all of you to attend the Congress, because I'll assure you that it will be a great Congress anyhow.
Okay, thank you very much, and we would be very glad to attend the ESG 2020 meeting, even if you announce it as a virtual conference, or we will be coming there to attend your the Congress as well. It will be a really good chance for opportunity for us. So thank you so much, Dr. Prato, for your valuable time in giving us and giving more insights on how to manage diabetes with COVID-19 during this particular period. As we all know that everyone are confused and aware about how to deal with the situation. And I believe all our audience have also received a lot of insights from your presentation, as well as during the question and answer sessions. So we would be, we are very glad as a Lupin team to have you here with us for the discussion, sir. Thank you very much for your valuable time.
Yeah, I really like to thank you and Lupin team for giving me this opportunity, and allow me also to thank at a personal level all the colleagues to take time out of this busy time for being here and listening to me. And I thank you very much for your questions, and looking forward to see all of you in Vienna.
Sure, yes, sir.
Or at the Congress, okay? Or at the Congress.
Yes, sir. Yes, sir. Thank you very much.
Have a great evening, you all.
You too have a great evening, sir. Thank you very much.